second edition of the Simply Endo podcast. We had some great feedback from the first one, which is fantastic. So if you've not had a chance to listen to that, please do. Obviously, our first episode with Mike Horrocks. We've positively gone downhill now because there's me and Rob, and we're joined by none other than Lee Valentine. It's funny because we did a very original pilot podcast that we made a few years ago of a bit of a practice really to see if this would work, and it was the three of us then. It was quite good fun, so it's good to do this again. For the sake of sort of confirmation of dates, it is New Year's Eve. New Year's Eve.
8 o'clock in the morning on New Year's Eve.
Yeah, it's commitment,
sat
isn't
in the
it?
conservatory.
Yeah, it's commitment. What have you chaps got planned for New Year tonight?
I'm going out for a fancy meal this lunchtime over at the Three Fishes, darling, because my significant other half, she fancies herself as a bit of a gastronome. You know what I mean?
Right.
Yeah.
So you won't see the New Year in then, will you?
No, I don't think I've seen. I'm 54 years old, Rob, and I think I haven't seen a New Year's Eve for the past 6 years. I'm in bed by about 8:30. I always think, oh, I'm going to watch Jules Holland, and then think, oh no.
It's always Jules Holland, isn't it? It's always on.
Yeah, but it's filmed in July, isn't it? So, so they've all got the Christmas jump. They just never fit.
Well, at least you won't get knocked over by the winds.
Yeah. Well, yeah, it's supposed to be bad as well tonight. Yeah. So no.
What are you doing, Rob?
Very quiet one for me, actually, Dave. 'Cause as you know, it's been a bit of a hectic few weeks, few months, really, in fact, years, life in general. And so we've deliberately kept this Christmas quite quiet. So I am playing golf this afternoon. And then I am going to cook steak and chorizo fajitas. Kate and Hermione are going to watch Wicked. And then we're just going to come back and just have a bit of a chilled one.
So you can tell listeners that we're orbiting different planets. You had Mike Horrocks last time. He's having chorizo fajitas. I'll probably be having beans on toast after not enjoying me New Year's Eve lunch. What's this? What's that? Oh, I don't like that. I'm going to turn into Dave.
Hey, no, it's.
What about you, DB?
It's my eldest little girl, Heidi. It's her birthday today, as you probably know. So Heidi's 14.
Happy birthday, Heidi.
Yeah. I'm surprised she's not up yet. I thought she might have been up and causing chaos. So, so we normally do. It's a bit of a sort of a tradition that we go to a panto. So today we're actually going to Manchester to the. I think
Centre
Jason Manford's in it. Yeah, absolutely. Yeah. So Jason Manford in. I don't know. Is it Cinderella or something? Yeah. So it should be good. So we're doing that. So all the family's out for a bite to eat beforehand. So 14 years ago, we were in the hospital waiting for her arrival. So, I had the pleasure of sitting around. I better be careful what I say here, haven't I? Cause
yeah.
There's a percentage
we're going into dodgy territory now. Female
listeners who will, complain about how hard the job is. And I can see my wife out the corner of my eye there as well. So, yeah. So I did my bit. I just kept out the way. An egg and mayo sandwich. Yeah, that was my highlight.
We'll make sure you got some cigars in.
Yeah. So that's today. So it should be good. Well, we said we'd chat and catch up really a bit about. Obviously, we want to talk about endo and stuff. It's been interesting to have a little bit of a break from all things Simply Endo, but we wanted to chat a little bit about emergencies because at this time of year it does go a bit manic, doesn't it? I don't know about yourselves. The way Christmas has fell this year has been a bit odd. So some people have probably not had a lot of time off. I think I've always worked kind of up to Christmas, really, because of Christmas Eve and bits and bobs. And the one thing that amuses me is the people who turn up, 3 or 4 days before Christmas in a panic because you're going to be closed for a couple of days. I think they're quite hard to treat. Those sort of patients who, this has bothered me for the last 9 months, but I know you're going to be closed for, a day or something.
I'm going on holiday in the new year.
Well, you get the same in the summer, don't you? You get the holiday panickers as well, don't you?
Yeah.
What do you guys do just in a routine day? Then ignoring Christmas, how do you structure your emergencies in a normal day?
It's always something that when you read textbooks and you listen to other people about how they structure their days, you think, maybe I should have some emergency appointments set aside. But there's a couple of elements of it to me, like a touch wood. I honestly don't get that many sort of emergencies on a daily basis of people, because my practice is weirdly mainly limited to endo. But the way that I get my referrals in from other dentists in the area, they have usually got the patient out of pain before I see them. So because I don't see many general patients as well, I am in a fortunate position. I don't really see that many emergencies. So by having
It's not helpful
slots,
at all.
Say again.
We don't need that. We wanted nuggets.
But what I'm saying is that I don't have specific slots in my day. So sometimes there is a bit of juggling that has to take place, that I sometimes, when they do come along, think, oh, I wish I'd got something. But I usually end up, like we all do, usually work through lunch or stay late or come in early if there are people like that.
Do you get many flare-ups and things then of cases you're doing, or do you think you don't? Because most of your stuff done in one visit.
Personally, I find that it depends which way the wind's blowing, whether I do things in 1 or 2 visits a lot of the time, and that's usually related to either patient fatigue, or there are specific circumstances, like if the retreatments, I try not to do them in one go. But flare-ups, if I do get them, and we all get them, don't we? But I find them anecdotally usually with retreatment cases where you stirred up the hornet's nest. Do you know what I mean? And I'm very careful to tell them that it'll be, we've done a minor surgery inside your tooth. It's like a hornet's nest. I use sort of phrases like this for patients, and that it's not unusual for it to be, painful afterwards. I think sometimes part of managing emergencies is sort of prepping the patient that they're going to experience some discomfort afterwards, and that's normal. I call it sort of a healing pain to the patient. So I often think as well that I have heard people in the past have little cards printed out, like post-operative instructions and what to expect and how to take. I go through a bit of a preamble with them beforehand, but at the end of the appointment, they're knackered, you're knackered, you may be running behind. I always think, it'd be quite good if I could give them something, because whatever you say to a patient at the end of an hour or 2 hour appointment, it just goes in one ear and out the other, doesn't it?
It's that vortex between the surgery and reception, isn't it? So you go through all the instructions, and the receptionist comes back in. Well, when can they eat?
And you've just mentioned it all to them. I think sometimes, I don't know whether it's something I should put on my website as well, but then again, patients don't always do that. So, but in terms of like scheduling emergencies, I'm sorry, I don't have tons of them. When we get flare-ups and stuff, we try and get them in, give them antibiotics. You'll be fine.
They've often got them from someone else before. It's amazing, isn't it?
My sister came in yesterday. I was before we started recording with this swelling on this tooth, and she said, "Oh yeah, I had some amoxicillin. I've been on them for a week."
Yeah, it's amazing. But I always find it funny when people say, "Oh, I've been taking painkillers because my auntie's had a bad back or something."
Definitely.
And they've been taking you sort of think, gosh. So, what do you do, Rob? Do you have because you're doing still some general stuff as well, aren't you? So do you have set time in the day?
Yeah, definitely. I mean, obviously, I'm trying to kind of wind that down now. But I mean, if I kind of talk back as it was, definitely had quite a big general list, at one point. So I had an hour a day. I have an hour a day between 12 and 1. And what I find really weird though is toothache is seasonal. So in the summer, I often get 2 hour lunches, which is great because there's always something to do in the simply endo stuff or notes, X-rays, whatever. But in the winter, it's round, which how toothache is seasonal, I'll never know. But
do you think there could be something in that though? I wondered this about. Often we talk about the immune system and dealing with things. I wonder whether there is something, but somebody's probably done a study that we should know.
Changes in atmospheric air pressure, favouring anaerobic bacteria or microaerophiles. There you go.
I think the big thing, for me though, was just kind of getting the reception team on it as well. So getting a decent history, and then I generally don't let them book the emergency. I mean, if there's nothing, there's chipped tooth or something like that, that's fine. But if you've got like a 2 or 3 or 4 or something like that, then kind of, I want the history, and then I want them, they bring it to me, and then I say, right, put him there, do that, do the other. Basically trying to end up with the one that's going to take me the longest at the end, with it. Patients are cute as well. I mean, I get some patients that know exactly what to say, and they get seen.
Trigger words.
Yeah. And they come in and there's nothing wrong with them. But that's just the nature of the beast, isn't it? But
the difficulty with that, though, Rob, what you're saying, and I get what you're saying, sometimes and staff will come and ask me where should I put this patient, all that. But then I do sometimes think, if I'm working out where they should all go, why am I bothering with you on the desk? Do you know what I mean? You kind of think, like, if I'm doing your job as well.
You suggest that?
Yeah, I haven't suggested that, but it's in my head. There's lots of those things, isn't there, that are in your head that you think, I best not say this. But in my head, I think, what's the point in you being here if I'm putting them in the appointment book? But I know what you mean. I think maybe there has to be a bit of balance. It's those ones that come in and it says lost filling, because most of mine, I'm probably somewhere between the two of you, so I'm not quite completely endo, but this not. I think I have a morning of routine stuff on a Wednesday morning, and then the rest is endo.
Yeah.
So I do get some bits of emergencies. I get some bits of emergencies when the associates are not in. So if it's their patients and stuff, but it's those ones where it says lost filling, and they come in and it's a crown, and it's their front tooth and the whole core's inside it, and you think, oh man,
they're going to Spain tomorrow.
Yeah. But then the advantage of them going to Spain tomorrow, at least if you stick it on, it doesn't come off. They can't badge you for a couple of weeks, can they? Hopefully they'll see in some Spanish dentist. But no, I don't. I get a mixed bag of stuff, really.
I think, and another element to this, I suppose, with a slight salience to the Christmas holidays, is I'm interested to know: when you're about to go on holiday or have a Christmas break, do you sort of tailor the patients that you see in the last few days before you go away? Like will you start endos? I know the implant really guys at our place tend to, like, the last week not be placing so much.
So I've had patients where I've thought, I could finish this now, but it's maybe been one of them where it's been, maybe I've done it over 2 visits, but it's been a bit niggly. And on a normal day, you would go, well, I'll finish it, and then if there's a bother, I'm going to be here. But there was a couple just before Christmas that I actually just dressed again.
Yeah, you start shying off them a little bit.
Yeah. And you wonder whether that's just crackers. You see, what I was thinking about with Christmas and stuff, obviously, and we come back to your question, Valence, but for me, the 2 days that we've been effectively closed for Christmas is just like a weekend, isn't it?
Yeah.
And what I found going way back, we always talk about COVID, don't we? But going back to COVID, I think through the whole time that we were closed for COVID, which I think was from the March till the June, I can only remember maybe 3 real serious, sort of cases of toothache or problems with patients. I don't remember being that inundated at the time. And I know we weren't, as a practice, we weren't as busy then as we are now. Yeah. But I think people seem to learn to just kind of get on with stuff a bit, didn't they?
Yeah, definitely.
And I think maybe there's a bit of mindset with it. So it was interesting you were saying before we started, Rob, that you've been quite quiet really over Christmas and stuff. I mean, you've not been as busy. Do you think people are learning just to get on with stuff, or are they all going to Turkey?
I generally don't know. I mean, like, obviously we provide the emergency stuff in the weekdays, but on the weekends and bank holidays, we're part of a rota, and there's about 10 practices that we're on. And I got Boxing Day, which is historically the worst day of the year because people kind of hold off a little bit before Christmas. Then it gets really bad. They don't want to spoil their Christmas dinner. And, we have to kind of keep a log, a book of all the patients that we see, and so it can be audited, etc. And, looking back through the book, Boxing Day, 8-10 patients. And this year I got absolutely nothing, and it freaked me right out. And all you do is watching all day then. And then I covered the practice on the Friday because I thought, well, I might as well work the 30 Friday. And then I kind of got yesterday and today off, then back in on Thursday kind of scenario. And again, that's the first day back after Christmas is always busy with the broken teeth, the chipped teeth, etc. from all of us together, and there was nothing, absolutely nothing, and it's really, God knows what. I'm dreading going back Thursday.
Yeah, be totally rammed.
Yeah.
But I mean, I think the big thing for us is, though, my emergency spot isn't really emergencies. I probably have a handful of emergencies. What I would call emergency a month.
Yeah.
It's that, maybe a couple of months.
I think there's that disconnect as well, isn't there, as to what we assume are emergencies and what patients are. Well, I used to jokingly say to my receptionist that unless they were bleeding out of 2 orifices, it's not an emergency kind of thing. So, but to a patient, like you were saying, who'll have chipped a tooth, as Rob says, it's a big deal to them. So I think sometimes there's a bit of patient management, isn't there, as to trying to sort of keep everyone happy, but you don't want to be overrun with trivialities in your mind. Do you know what I mean?
I think the big thing, I know what Lee was talking about earlier, prepping the patients. I think the big thing for me is just warning patients that post-op pain peaks at 48 hours. It's going to feel worse when the anaesthetic wears off. It's not going to feel
and it is
bad.
Completely normal. I use phrases like, it's like if you'd gone and had your tonsils out, or an appendectomy or something. It's like, it's not going to be fantastic straight away afterwards. And it's the similar, you've had a minor surgery done inside your tooth. Not trying to, like big it up as though, you've had a minor, but and to expect some discomfort is normal. I think sometimes if you don't tell patients that it's going to be uncomfortable afterwards, because we're all busy, I think they worry that it's because, and it's almost inevitably those cases, when people are coming in, they're not having any discomfort, but they, their dentist has said it's got a big area, or, they're going to have some crown and bridge work or something. And, it's been picked up that they need some endodontic attention. And then you do something and it's sore afterwards. They obviously think that it's going downhill, So I think that reassurance before, remember the number of the devil that I've spoken to in the past, 666. It's an Alan Nasser phrase, and he always says in all the years I'll never get his name right, but he always tells them about the number of the devil, 666, and he says for the first 6 days it's going to really let you know about it. And for about 6 weeks, it's going to feel uncomfortable. It won't be completely fine. But by 6 months, I'm expecting on the X-rays, everything to be starting to heal up and things like that. And I actually tell them that it's the number of the devil. For the first 6 days, it can feel sore. So you're going to need pain relief, and then caveating that as well. But there are circumstances where I do want to see you again. For instance, if it's swelling or it's getting worse every day. Because it may be uncomfortable, but it's tapering off in the right direction each day. What you don't want is for it to be tapering off and then reversing. That's when I want to see you again. And you say this to everyone, and most people take that on board. And I'll see them a couple of weeks later if it's a 2-stage thing, and they'll say things like, "Oh, I'm glad you told me about because it let me know about it for a couple of days afterwards." And you think, they're quite happy because that's what you said was going to happen. And if you say it and it doesn't happen, they think you're fabulous. Oh, yeah, you said it was going to murder me. And then I still say the same thing after the second appointment on a 2-visit one. So I'll say, well, you didn't get any aggro the first one. That doesn't mean, you'll probably get it this one. Do you know what I mean? Yeah. So they're kind of expecting it.
What do you do, Lee, when you're opening a tooth up, isn't it? Because, we talk about it on Simply Endo, and we talk about, never touch a canal unless you're going to fully prepare it.
Yeah.
I mean, and the delegates, they always look at you as a little bit wary about that. They're not fully on board with that, are they?
Yeah.
They don't...
Me in particular, are you? Is that just me when I say it? Yeah.
No. We all say it.
I don't think he knows what he's going on about.
But how do you find that process though?
So for me, it's almost for the management of people who are in discomfort and you've decided you're going to do something. Let me just be clear about one thing. There is no such thing as an emergency retreatment appointment. So if somebody's having a lot of pain and it's a retreatment, and it will be a retreatment, previously treated endo, I think it's called, and they come in and they're having some discomfort with that tooth. I always remember the legendary Stevie B saying there's no emergency root treatment, because if you start rushing a situation like that in terms of trying to get all the GP out, get some patency to medicate it, which is obviously the ideal situation, you haven't got time in 10, 15, 20 minutes to do something like that. And when it goes wrong, they are the ones it's going to go wrong on. So that is a case where analgesia instruction and or plus or minus perhaps antibiotics. There are a few situations where we rarely prescribe antibiotics, but that's perhaps one. But necrotic cases and irreversible pulpitis cases, we've spoken about this at Simply Endo in the past, they're just taking the lid off the can scenarios, aren't they? They're both caused by increased pressure in non-compliant environments, aren't they? So like bleeds inside a person's skull and stuff, part of the pain and discomfort and is to do with the elevation in pressure. So simply de-roofing the pulp chamber in a necrotic case or removing the coronal pulp in an irreversible pulpitis case is in itself enough to relieve that discomfort. If you've got a necrotic case and you start half-hearted, like just kind of having, just see if they're the canals there and there. What you're then essentially doing is either inoculating parts of the canal that aren't overtly infected, or you just, for instance, an irreversible pulpitis case, you're just stabbing already inflamed tissues. So you're sort of compounding the issue. It does make sense because we all go, oh yeah, was it? I'll just check that all the canals are there, so when they get them in next time, we're flying, aren't we? But I think the problem of doing that is that you can kind of make the issue worse. So those are cases then where I will just irrigate, arrest the hemorrhage in a pulpitis case, and then use either calcium hydroxide or the green stuff in some cases.
Well, see, the one that because obviously that's a top. I get asked about that all the time. Calcium hydroxide versus the green stuff, as you put it.
Yeah.
Or yellow.
I anecdotally find the green stuff quite useful, but as Dave says, more often of the time I'm doing it for myself than the patient. I'm not so sure, but it does tend to work in pulpitis case. In a necrotic case, I'd probably use calcium hydroxide, but in someone who's having a lot of aggravation, I feel better. And I think sometimes as well, students and other dentists get concerned that, if you're not getting inside the canal, is it not going to carry on? A, generally, no, it doesn't. But B, I'm not then leaving the patient for 3 weeks before I get them in again. It's just a procedure that creates a bit of space so that you can alleviate the discomfort. It's not disrupting your schedule massively, and then you can reschedule them for the day after or the day after that. It's not like I'm leaving them 3 weeks before we get in and then carry on. And I think sometimes I don't, make that clear enough. It's not like we're just going to go, see you, come back in 3 weeks.
See, arguably, you could say that it doesn't really matter. I often joke saying it doesn't really matter what you put in. I always joke, say you could sing the pulp a little song, and often I do sing a little song when I'm joking about it. But I think that it's that pressure relief, isn't it, or change in environment.
It'd be better if it just made a sound when you took, like when you're opening a can of beer. If you just that's better. But
then again, that's how I describe, when people get flare-ups, sometimes it is a bit like the opposite of shaking a bottle and putting the cork on top, isn't it? I think I'm very much aligned with you, though, Valis. I'm probably more inclined to use leather mix in those vital cases, probably because it does make me feel better.
Yeah, and it does. I mean, people have been using it since 60s, 70s, 80s. So it and we don't talk about anecdote, do we? It's Simply Endo, but it's just it kind of seems to have a generally good effect, doesn't it? But I think one of that kind of approach to treating emergency endos is, so if it's a retreatment case, then I'm not going to start it. I'm going to give them advice, palliative care, anti-inflammatory instruction, potentially antibiotics. But the other two, if they're in, if they are in distress, I think a lot of the stress on the dentist part comes from like, oh my God, I'm going to have to get all my endo stuff out, and it's going to take us 30 minutes, an hour. It really isn't. The most difficult part is obviously an irreversible pulpitic lower molars, is getting the thing numb. And we can talk maybe about pre-medication with NSAIDs later if you want. But a particularly long appointment, because if we can, in a necrotic case, I'm not really bothered about people using rubber dam because the tooth's already infected. And I think the other difficulty is access for all of us is probably the most hairy point of it all, isn't it? Especially through crowns and fixed bridges and things like that. So access, even under the most ideal circumstances, can be a little bit hairy, can't it? But I think just in terms of armamentarium, just like simply numbing them up, for me, just one clamp rubber dam on, make your access, take the lid off, give it a wash, a little bit of cotton wool. I don't like cotton wool generally, but I will use it in pulpitic cases because proper academic here. There's a bit of sponginess. We're trying to.
Like
if you put
don't you?
PTFE in it, I'm just thinking, well, I'm kind of putting the lid straight back on it. Do you know what I mean?
Yeah.
But a bit of sponginess. I don't know.
I think the same thing, and I think sometimes when I get people when they come back and things have flared up, I don't know whether just ones I noticed sometimes the temporary is kind of sank and it's all a bit squashed.
Yeah.
And I wonder whether you've sometimes lost a bit of space.
Yeah.
What do you think? They're just not putting anything in it though. You know, people. Yeah. I remember it was Castellucci. I think had said that at Dentsply that he didn't put it. I mean, he was irrigating teeth with 6% hypochlorite
uranium.
But he was, but yeah,
he nuked it first.
But he was not putting calcium hydroxide in. For me, calcium hydroxide is obviously there to elevate the pH, works as a bit of a barrier as well.
Yeah.
But he wasn't putting anything in it.
Yeah, and there's an eminent endodontist who doesn't live a million miles away from where I work, who had a PhD in the effects of calcium hydroxide, and he just hated the stuff because you can't get it all out. So, well, that's a whole other kind of debate, isn't it?
Yeah.
But yeah, so in terms of emergencies, but I think we might have put the cart before the horse a bit there as well. I think another really important part of the management of emergencies is the diagnosis as well, isn't it? You know, like getting it right. But patients will often come in and go, "Oh, it's killing me," and most patients are right, but there should be an index of suspicion that what they're describing is actually what they are describing. So a thorough examination and sort of remember me banging on about my PPPMOVX and stuff.
I see this on boards and computer screens every now and again when I go into Simply Endo, and I see it. You put it on forums and bits and bobs. What on earth is all this, Alice? What is PP? What?
So you remember basically? So when I were a lad, and I used to read the Bible that was Perils of the Pulp or Pathways of the Pulp. I remember there was a big chapter in it it's called the SOAP sieve, isn't it? And SOAP stands for Subjection Objective Testing, Assessment and Plan. And I always remember this from when I was doing my MSc at Manchester. And subjection is just that sort of asking the patient about, you know, the symptoms and, you know, the usual, when did it start? What initiates it? Is there anything that relieves it? How would you describe it? You know, all that. So you get that sort of report from them. And I have like a template on R4, and it just comes up with like that first bit. So the nurse or me will just go, you know, like just a quick resume of what they're saying. And the objective testing is the PPPMOVX bit. So that's all the students in my crew usually know this is, yeah, because I bang on about it all the time. And it's just because, so sometimes you'll get students or dentists will ask you stuff, and I know Simon's great when he's helping students out when they email stuff in, and he'll say, have you tested this, and what was the finding for that? And if you do the PPP, and then the student will go, oh yeah, I did test that, I'll get them back next time and ask them. But if you do the PPPMOVX, you'll usually collect all that stuff that Simon will ask you about. Do you know what I mean? In some way or form. And the 3 Ps are the palpation, the percussion, and the periodontal probing. The M is the
4 Ps then, couldn't there?
Say again.
Is periodontal probing 1 P? PPP. Right. So palpation, percussion, and probing.
Yeah, so you're looking for that sudden loss of attachment, aren't you? Stuff like that, or just and it's only useful if you've got like 2222 2222. Where if you've got 54, you know, they've just got perio in that, so it's not that useful. The M's mobility, so you're looking for mobility of the tooth or the casting inside the tooth. You know, is it the whole? You know those situations where someone's got a loose bridge and stuff, and you're going, is the whole thing loose, or is the retainer loose? Is the post loose? The post coming with the root. So mobility like that. Occlusion, so like workers, non-workers. Are they like David Coulthard patients? You know, like with big square face. You remember the racing driver? And, you know, big giant masseters and all the fillings look like you could have a shave in them, you know, like really shiny ones. Because they're people, like my sister yesterday, they're people who just crack fillings. So when I see people like that, you're thinking, oh, is there a high likelihood of them cracking stuff? Have they got history of, got a bit of previous of snapping teeth? Mine was unrestored lower 7 that fractured. And then obviously with the occlusion, then I might do the bite, the tooth sleuth or the bite stick thing. And then the V stands for vitality. It's just that long ago that I learned that it's still vitality, or you'll get brownie points for saying sensibility. I actually used an electronic apex. I actually used electronic apex locator for the first time. I meant vitality tester the other day.
Pulp tester, did you?
Yeah, so old school pulp from Parkel.
Sorry, we're going to drift off, aren't we? Why did you use that then?
That was just a case of a lady and this was similar. She was saying it was this one, and I suspected it was this one, and I was like going, the patient's normally rightly, and so we did all this, and then we got to the vitality bit, and she had crowns on. So they always say endofrost is really good, even with teeth with crowns, but sometimes I don't find it that useful at all. And it was a situation. Yeah, do you find that? But when you read books, they always go, "Oh yeah, it's -50. Yeah. You can get through crowns." And I'm like, I'm not so sure. So I thought, right, well, I'll just use the electron, because it was like, when you're testing things specifically, a negative result doesn't really mean anything. It just means it's not responding, doesn't it? So it's kind of not, just because it doesn't respond doesn't mean there's anything wrong with it. Do you know what I mean? Sometimes. So I was still a bit confused about it because I haven't got to the V yet. So
what was V again?
Sorry, I've got to the X-ray bit. Okay, so I'm doing V, so I'm doing the vitality testing. So I thought I'd just use the Apex, the pulp tester, and the one that she thought it was the problem did respond, and the one that I thought was the problem didn't. And she had a little bit of recession around both of these crowns, so I could get the probe tip of the pulp tester underneath it, and she responded relatively early on the one that she thought it was, and not at all on the one that I. And the X-ray was, was the one that I thought. So when you go through all that, you've collected all that information, and then X-rays can sometimes be bite wings as well in diagnostically challenging situations where they go, oh, it's up here, and they've got big restorations down here and no restorations up here. So impacted wisdom teeth, occult caries under, crowns and bridges. I don't always take bite wings, but it's a very useful X-ray to assess the position of the pulp chamber. We were talking about access is a bit challenging, weren't we, before? And I think sometimes it gives you a good idea of depth, and also even with good bisecting angles, people with very shallow vaults and stuff like that, you still get this kind of superimposition of the crown margin or the restoration over the pulp chamber. Do you know what I mean? So sometimes it's useful for looking for caries in the opposite arch, but it helps you with your access sometimes because it's not as distorted an image sometimes. But
and then how often will you scan people then, Valas, as well?
So we are looking at, there's a couple of guys who work at our place who are big into implants, so we're lucky enough to have a scanner, and my students' eyes will be rolling back because they'll have heard me say this a million times, but I think sometimes a cone beam scanner, if you've got one, it's a bit like having electric windows on a car, isn't it? It's like wind-up windows are good, but electric windows, you wouldn't go back to having wind-up ones, would you, if you've got access to it? And I think there is people like Shannon Patel in the past who's written papers with Professor Harner about there are very specific circumstances, and don't get me wrong, I don't want people to be getting the impression that it's like a Buchanan-esque fire at will kind of taking cone beam scans. But there is definitely, I feel, a shift that if, more and more people take them, not I hesitate to use the word routinely, but they are becoming mainstream, aren't they? And you don't know what you don't know. But surgery cases or potential surgery cases, teeth that you think may suspect of being fractured, retreatment cases I tend to do, or furcated teeth that are retreatment cases. Although saying that, even single canal retreatment cases I've scanned and then found out that there's been perforation of it, but on a PA it looks completely centered inside the root canal. So you become across more and more situations where you think, oh, I'm glad I took that. Do you know what I mean? So, but not routinely, no. And not in the management generally of emergencies.
Yeah. See, I don't have a scanner, but I do think I refer them out, and I take more and more each year. I think looking back on them.
I think if you've got one in your building, you'll tend to use it more. Because obviously there's the inconvenience to the patient having to go somewhere else, and then the delay. But there are, I mean, I found it a big game changer.
We've had ours. It's got to be over 10 years now, and you can tell actually now when you look at other scans people are showing you, you can tell it's an old machine really. But and I've got to be honest, I didn't want to spend the money, because back then I'm sure it was 80 odd grand.
Yeah, they are so super expensive.
And plus then you had to spend a couple of grand a month on the software as well. It was a really expensive exercise, and and for 5 years didn't touch it because back at the time we were told, for endo you don't need a CT scan or CBCT scan, you need experience and a microscope, don't you? But as Dave just said, more and more, as time goes on, I'm taking them more and more and more, frequently now. Absolutely.
I mean, there's that great statistic, isn't there, where when given a cone beam scan, was it like the decision changing rate was like over 60% of what the dentist would have done without the scan? And I think that's quite sobering. That it prevents patients being put through treatment that without the scan, the outcome may have not been anywhere, do you know what I mean, as high as you thought it might have been. So it's prevented them having treatment, it's prevented the frustration when the patient comes back, oh, it's not quite settling, and you can't quite work out why. But, that's another topic altogether. But so, yeah, collecting all that information in emergencies. Sorry, I was going well segment then. So I think, that's important, because whether it's a referral to you or, your own patients or it's an emergency, I think when people present with toothache, that's just a quick way of going through things. And I'm not saying everything it needs an endo, but it's a good way of collecting all the information to sort of allow you to assess the magnitude of the issue and whether endo may be needed at some point in the future.
Yeah. Because I've just had a patient over the last couple of weeks or so, just before Christmas, and then he actually came in just after Christmas as well, just in the emergency session. And one of those names that, he's a really nice chap, but one of those names that you see on the appointment list and think, oh man, partly because you're thinking, I'm not sure if I know what the answer is here. Because he'd essentially had a problem where he'd bitten on something, felt like something was painful and like continuous pain since. So straight away you think, oh, he's fractured something. But quite an unrestored dentition, really. He was convinced it was upper right 4 and 5. But I've gone through all those tests and can't really. It's when they say, "Oh, it's really sensitive to cold," and then you put endofrost on it, and nothing responds. You think, really, So I found that quite difficult. I didn't use an electric pulp tester. Obviously, I've not got a CBCT. I'm not sure if it would have been warranted at the time. And then you're not doing very well when the patient turns around and says, have you been doing this for long? Because then you think...
You don't say that to me anymore, Dave. Look at me grey Jeremy beard. You'll be...
Do I appear that incompetent, But I couldn't work out what the pain was. He then came back, like I say, between Christmas and New Year. He came back last week. And one of them were, oh, it was really bad last night. And then when he comes to see me, go, oh, it's a bit better. And then I couldn't find anything. I do worry with tooth sleuths because I had used the tooth sleuths. I'm never quite sure. I think you have to be careful with a tooth sleuth. I always say if you're going to use a tooth sleuth, you have to be very ready so that if they do bite on it and it goes and the wall comes off, you have to be very quick, very ready to go, oh, well done. You've found the problem. Well done. You've helped us, rather than you've just broken.
That's exactly what it was.
Yeah. So, but interestingly, this chap, I couldn't work out what was wrong with him. So it was about trying to then reassure him. Then, and in the back of my head, I'm thinking, actually, is there some sort of atypical facial pain and stuff going on here? Is it? It didn't really scream trigeminal neuralgia, but that's in your mind as well.
And I remember you telling. Sorry, Dave. I remember you telling me cases in the, you've had you've had some really horrendous sort of examples of people presenting with toothache that wasn't toothache in the end as well, wasn't it?
Yeah, I mean, one of the ones that I talk about on Simply Endo was a lady who had been referred to me from a practice in Wales, and a bit of a strange one because the chap had never referred to me before, which is always a bit odd, isn't it? But that was a lady who'd had an endo started, had the tooth taken out because it didn't get better. The dentist, literally on the day that they took the tooth out, the pain moved to the tooth next door, and he started endo on the tooth next door, and these were unrestored lower anterior. And then and when she saw me, there's certain key words I think that people say, aren't there, that I'm always listening out for. Unusual words, so things like tingling or nerve type pain. I suppose as well, pain that doesn't wake them from sleep worries me, because for me, pain doesn't care. It doesn't care whether it's Christmas Day. It doesn't care whether it's your birthday. It doesn't care whether you're asleep. And often it'll come on worse when you're asleep, won't it? So the fact that it wasn't waking her from sleep. But it was funny with that lady. We did all our sort of testing and stuff and couldn't really come up with a reason why she was having such odd pain. And then I just got into a conversation with her, which I did with this chap the other day, which was a little bit more about them. A bit more of you act a bit more like a psychologist, don't you? Sort of. And that lady at the time, actually, I'd said to her, I said, in your life, what was going on when this pain come on? And she just broke down. And I think it was something like her daughter was in a bit of an abusive relationship and all this sort of stuff, really quite sad. So there was obviously this real emotional side to it. So we had to finish the endo that the dentist started, kind of knowing full well that it probably wasn't that. And then referred her off to a facial pain clinic, and they diagnosed atypical facial pain. But what was weird about that lady is when she came back, I saw her again maybe 6-12 months later, something as a review, and she was like a completely different person, smiling and pleasant. And not that she wasn't pleasant before, but just very different. And I was like, "Oh, is the pain gone?" She went, "No, I've still got pain." Like,
it just doesn't bother me anymore.
But yeah, exactly. I said, "But you see, Macri," she said, "Yeah, I understand it now." I think that really, it was hard for me to get my head around that. But this chap the other day, I think there's probably, there could well be an element of trauma from occlusion. He's got a bit of a heavy bite. I think maybe a bit distressed and worked up. So I said, "I tell you what we'll do. We'll book you back for a review." And I booked them back in with my wife. And Emma saw him, and the pain's all gone. So either something's gone non-vital or something, and it'll come back in a few months' time, or maybe it was some sort of occlusal trauma or something. What do you do with these people, chaps, when you can't work out what's going on? Do you have a kind of protocol of what you do if you
I think
can't
you've got
find the answer?
The first thing is to be sympathetic and be honest with people. And I often say to some of my crew when I'm teaching is that when you get old and grey like me, it's easy to say to people you don't know what the problem is. But when you're younger, it's like that example you just mentioned then, is that if you say, "Oh, I'm not quite sure what it is," and people go, you feel like there's a level of incompetence, or they're like going, "Have you been doing it long?" Well, I've been doing it 30 years. I'm not quite sure what it is. And I think I've heard you in the past, or Rob say in the past, well, we could do this one, and if it's not that one, we'll do the other one. But you'll be paying for both. So, when I'm not quite sure, the natural history of these things it will become more apparent. And I know that's not any use to you at this point in time, but there is a risk if we're not sure exactly what's going on, that we make your situation worse, kind of thing. And most people can get on board with that. And it's not like you're not saying to them, "Right, I'll see you in 6 weeks" or something. If I'm around if things are getting worse, but we could do this test and this test, and we can't really find anything. I'm not saying that what the issue isn't real, but we just can't find out what it is, and this is just sometimes the nature of toothache.
Just explain it to them as well, isn't it? If you talk to them, explain what is pulpitis, talk a bit about proprioception, massive detail, obviously, but just an understanding. And often you find that the patients then are apologizing, "Oh, I'm so sorry, Rob, I'm not being very helpful," and they walk out apologizing to you almost. And I think that's just because it's just the communication with it. And I think that's such an important part of it. But also, as Peter said, that they know that, they can come back tomorrow morning, you'll see them, and it's just those occasions where you just have to wipe your lunch, get them back home on time, whatever the situation is. you know, and just be ready for them.
And also not to be, as a younger dentist, I think, and just not to be embarrassed or feel that you don't know your job by saying to a patient, you know, I'm not quite sure what this problem is. I think that's difficult, that, isn't it, sometimes?
Oh, massive. I mean, I get, you know, like the business partner in and stuff, and we often, not often, but, you know, we will get one another in on cases, you know, every now and again. And, you know, when you're younger, people think, oh my God, they don't know what they're doing, they need somebody else.
Yeah.
When I go in the room or he comes in my room now, they go,
they look at us and go,
they go, oh, it's really special because they've got, I had 2 dentists looking at me, and it's a completely different mindset, which is just not great for the young guys. But, you know, we've all gone through it, but it does make it easier. I think that,
you get that problem, Dave.
Yeah, being a young guy, yeah. No, not anymore. It's funny, isn't it? I've noticed probably over the last few years, certainly at sort of teaching at Simply Endo as well, I'm probably the oldest in the room sometimes, and it is weird, isn't it? Because it shouldn't be the fact that you're probably the oldest there, but there is experience there, isn't there? And yeah, it's funny. With patients, yeah, I think hopefully I look a little bit young, but I'm quite happy to go and get others to have a look at stuff.
Yeah.
I don't like others coming in and doing stuff, because then my ego does take a dent. You know, like doing an extraction or something, you struggle with it.
I remember you just give us a shift with this.
Yeah, well, we had a nasty extraction.
Can of spinach.
Most of my stuff is just endo, and it's endo because I'm pretty rubbish at other stuff. You know, I always joke about extractions, that extractions for me were like talking to girls. I could make them laugh, but they didn't want to go out with me, you know. So I get teeth incredibly loose, but could never seal the deal, so to speak. So, and even with you know 12 months of being an SHO in oral surgery, and I mean I did that oral surgery job really because I was naff at taking teeth out, and I knew if I was in oral surgery, I you know, no one else would. They would help you, but I couldn't go, oh, I'm going to access it and dress it instead. You know, we had to take them out. So I certainly got better extractions, but there's still things that you struggle with, and you think, oh, actually, albeit a diagnosis or albeit treatment planning, working something out in your head,
I think,
or actually doing something, you think, actually, I get someone to have a look. Yeah. Well, I'll try one. I'm not very good at that.
If you do 2, you can always say you've done a couple. Have you ever done this before?
What do you guys feel about What do you guys feel about when you get swellings and stuff like incision and drain? Because I find I'm very confident with incision and drain if they're buccally, obviously with the exception of lower premolars or something. It's when you start getting stuff palatally. We had quite a nice, nasty palatal swelling just recently on a guy who'd actually been referred as an emergency, which was a bit weird. His dentist had, I got the impression, you were talking about retreats not really being emergencies, and I get that. But this was one where I get the impression his dentist had left the tooth on open drainage, which, as we know, is not brill, big area on it, and then got him back in and actually just filled it, you know, just actually obturated it. So I did have to he had a big palatal swelling from his lateral. So I did actually work through lunch, got rubber dam on and everything, opened it up, and the GP just fell out and all pus and everything came out. But I did sit there looking at the palatal swelling for a little bit thinking, should I incise that? Because we were always told when I was an SHO about the difficulty of incising palatal swellings because of where the palatal artery sits, and especially when they're swollen, the distortion of anatomy then. What do you guys think of these things?
I didn't think about it much until you just said that.
There you go.
Thanks for that, Dave.
Yeah, it's all right.
No, I think that if somebody's got a considerable swelling, I'm not really averse to using a 12B to just pop it, but I'm not going to be starting, you know, like a huge incision around it. It's more like a puncture, and like just getting a spot and just squeezing it out. But yeah, I am. Again, going back to my sister yesterday, she had a bit of swelling towards the palatal, and I was thinking, do you want me to do this? Do you want me to do this? But you're right, you do get these. The more you know, the more apprehensive you become sometimes, don't you? Because you're aware of what can go wrong. When I was a young jobbing dentist, it was like, you know, oh yeah, we'll have a go with this, but because you don't know what the, you know, you're not often aware. But sometimes it can paralyze you, can't it, having that kind of knowledge? But I think, for me, listen, if there's a small, you know, from making a 0.5 to a centimetre long little puncture wound, I don't think you're going to really be worrying too much in those situations.
Just better be careful with those, isn't it? And just not shoving it in, isn't it? Just gently, just peeling away almost. When you're doing them. Maybe
what do you do about getting them numb, Rob? Do you get them numb? Because obviously old school used to be spraying ethyl chloride on it, wasn't it? And just going for it. But do you try and get them numb? Because I used to try and put like local around the area, but
I just use like endo snow. Sometimes just like, because sometimes it comes with a straw. I don't know if you can use like a. Yeah.
I did put topical on. And
you tell me it's only a second. You're gonna feel a bit of a whoop. Just grit your teeth. I'll get the armrests out for you.
Yeah, strap them in.
I have superficially infiltrated. I know, obviously, that the big concern of that, and the big risk is spreading infection, isn't it? So if you are going to do that, you obviously have to make sure that you're going to pop it, because do more harm than good. But because of the pressure, because of the mindset, and a bit of topical, I generally find that works quite well.
Yeah.
I think just going back with the diagnosis and some of the weird stuff as well. I think one of the big things I find so useful, on a fairly frequent basis is Lucia jigs, and just a way of just ruling out, when I'm not talking about football biters or necrotic pulp, but those ones.
A retreatment. I'm just going to put you in a Lucia jig.
The ones where you're just not sure, it's bouncing around a little bit and all that kind of stuff. And I just find them, they're quick, they're easy to make. I know some people use them as a long-term thing. I'm not a big fan of that because I worry about over-eruption and push, the change in the position of the condyle. But as a short-term diagnostic tool, I think they're brilliant. And also for occlusion issues as well.
Just obviously, I know you won't want to spend the whole time talking about Lucia jigs, but for the sake of those people who might be listening who don't know what these are, Rob, potentially including me, what do you do?
So
I think I know what you're talking about, but I don't want to assume I do, and it be completely different.
So you're basically creating a flat surface over the
just the anteriors over the incisors.
Yeah.
Okay.
So you're
and what do you make out of
them. So I buy little templates, and then I get these little plastic beads that I can melt, and then I can kind of create the tape. But ultimately the lower incisors are on this flat surface, a couple about centimetre wide, 2 centimetres long. I used to make them with acrylic, and
you can get, if you go to what's the Great Lakes Orthodontics, you can actually buy Lucia jigs that you just reline with like jet pipe.
That's what I do. That's in effect what I do now. But that's absolutely what I do. I just use the beads. Because
like the MTS-ISS thing.
Yeah. And it's great because you can do it quickly. Patient feels like they're getting something, and then you can just, it helps. I say, look, this isn't going to cure it, but if you come back and they're significantly better, we know we need to go down this road. And I do, people with headaches, neck aches, back pain. The number of people I've helped make that by, I call them centric relation appliances. I'm not the Tanner appliance, where you're balancing CR and CO. And, Lucia jig to start with, if they come back, headaches are gone, neck aches are gone, they think you're a genius. The problem comes with the ones where it has no effect, and they think you're raving mad that this bit of plastic between their front teeth isn't helping their toothache or their neck pain. But I just think it's a great thing, for a occlusion.
And then if it works, you've got a full mouth reconstruction on your hands. Brilliant.
Well, no,
holidays for the next 2 years for you, Rob.
I tend to put them in the appliances then, which I quite like making them. They're quite. It's a great way of just reinforcing your occlusion. You basically put in this mutually protective occlusion. And then, I think to me now, like, I have done a few of those in the past, but those days for me in full mouth are long, long gone. That they're going off to see somebody else now.
Same here.
Yeah.
Mr. Valentine.
Yeah. No, it's really interesting because I've seen them. I'll be honest, I don't think I've ever made them. I used to work with a guy who used to make them a bit, but I've never made them. But it's interesting, Rob, to do that, to give them that bit of a breather. So yeah, good. I was going to ask you, as we obviously don't want to take up all your morning and stuff. Obviously, we've had our years almost at an end. New Year's resolutions, dentistry-wise, rather than losing weight or something like that. But dentistry-wise, have any New Year's resolutions or things that you want to tackle or try or do? See the faces you're pulling. Go on, man.
Right.
What's yours?
You can't lose,
Who's got a pen?
you can't lose any
Who's
more
got a
weight, fellas,
pen?
can you? You can't lose any more weight. You'd be wasting away.
My New Year's resolutions. I wish I could just take it a bit more easy about dentistry and not get so worked up about it sometimes. I think anxiety is contagious in a dental practice, isn't it? I think dentistry is sometimes like full-time hostage negotiation, isn't it? And the stress kind of, those patients who lie in the chair and the only two bits of the chair they're touching are the heels and their occiput. Do you know what I mean? Like that. You can just feel the tension, can't you? And sometimes endo gets a bad rap because obviously it's a bit like, I think endo is dentistry's equivalent of like fisherman's tales for patients. They go, oh, I told my sister I was going to have an endo. She was going, oh my God, it's murder. So, so people are just, everybody likes to think that their endo's got the worst ever experience they've been through, isn't it? So I think sometimes that sort of the anxiety of patients is sort of chronically corrosive towards dentists over time, isn't it? And it's hard to. You're always easygoing, Dave. I don't think it affects you that much, does it?
I don't know. I don't think. Monitoring blood pressure at the moment, but I think yeah.
Apple Watch.
No, it's that swan thing, isn't it? Your legs going like Billy-O under the water. There's bits of it that don't bother me, but I think lots of it must do. I think I don't look at what I've got in the following day.
I never do that.
But then sometimes you get in and you think, oh God, I've got that in, I've got that.
I should have done a bit of reading about that.
I think my problem is the two voices. The one that goes, oh no, this tooth is knackered, you can't do anything with it, and that's the voice you should listen to. And then there's that other voice that
just have a go.
Have a go, Dave.
Yeah, just have a go.
And unfortunately, that little voice every now and again comes out, and I'll say something to the patient. I think, oh man, and then they're booked in, and you think, why have I agreed to do a surgical on that when it's totally knackered, or hemisection and stuff we were talking about before. I think it's very hard to be easy going with dentistry, isn't it? I think you need a breather away from the practice and stuff, which I'm probably guilty of not doing. I think my time.
But you're only a young lad. You're only a young lad.
Yeah, so they said, but my brother was telling me off the other day. My brother, when he's off, he's off. You know what I mean? He doesn't do any work. I don't think he does much work when he's in, but I think when he's off, he's definitely off. But he was saying to me, he said, oh, you need to take some time off, Dave. And I said, well, I'm actually off. Weirdly, I've got 2 days off next week. And he said, oh yeah, but you won't be off. And I thought, well, I won't, because I'll probably be reading dissertations or writing, keynotes or something, which I don't mind some of that. But as well as getting mithered by the practice, that's hard. Getting phone calls, I think that's difficult. But yeah, I think if there was a way of relaxing but you do a thing, Valas, don't you? Do you work so many days and then you deliberately have so many days off or something?
I try not to work more than 10 weeks continuously without having a week off. And that's just something I used to know a GP when I was younger from university, and they was going, oh yeah, you mustn't work more than 10 weeks continuously. So some years, usually today or tomorrow, I will sit down and look at the calendar and get my holidays booked in. I also listen to a bloke called Kirk Berendt. When I used to do quite a lot of the Dawson Academy stuff over in the Wirral with Buckle. Do you remember?
Yeah.
He's nice, really nice guy.
Buckle, yeah,
but they've got this guy over who was like a business consultant from a company called Act Dental in America, and the guy was called Kirk Berendt. And he was really interesting, and he was going on about I think this part of his lecture was called The Power of 32, and he was saying you can't work more than 32 hours a week, clinical hours at all. He says you can't. He says you can't make enough money in 32 hours a week as a dentist. He said you're doing something wrong. And I thought, like when you sometimes hear like business consultants and GPs, people who are not actually in the game that you're doing, say stuff like that. I think sometimes you're in that hole digging so much that you sometimes don't take on the philosophy and the advice that other people that can see from the outside in. And I thought, you don't work more than 32 hours a week and try not to work more than 10 weeks a year. You know what it's like. We don't always manage to pull it off, do we? But it's sort of the sort of yardsticks that I try and keep to ish. But I'd like to, and this is the other thing that I like talking to the students about. This is one of the great things about meeting young people at Simply Endo. I love quizzing them about how many hours they're working and the style that they're working. And nobody works 5 days a week anymore.
Yeah, they have
4.
the balance right, don't they? They have the balance
Why am I
better.
working 5?
Yeah, they have the balance so much better. It's weird, isn't it? Yeah, they're from the start. Whereas I've always been of the mindset,
such a refreshingly good attitude towards the work week now. I think young people. I think I came from that generation where it's like, we're going to work 9 to 5. And I'm not saying this is all the delegates, because some of them work 6 days a week. Some of them work Sundays, the occasional Sunday, which I think is crazy. But by and large, they've got a better work life. They've got a better. I think younger dentists these days have definitely got this kind of. We're in it for the long haul, so there's no point in just doing ourselves in.
Well, let's go to the other extreme now, and that's you, Rob. Because I think what's interesting with you, Rob, you work incredibly hard, which you do, don't you? But obviously you have travelling as well, which I think is incredibly tiring as well. What do you think of Lee's advice of taking it a bit easier?
Not doing anything.
No, definitely. I think I've got a good friend of mine. He works 8 weeks on, has 2 weeks off. That's his pattern. And he's got several NHS practices down in South Wales. And he was saying as well, he noticed no difference in his productivity. When he did that, and they're saying like the 2 days before Christmas, you're knackered, aren't you? You're not productive.
Yeah, it's funny. You're right. When you're coming up to a holiday, those last couple of days, I don't know if that's psychological, but you just think I can't work another minute.
Oh, definitely. And I think there's a lot of sense with that. And you've got to, just as you say with the younger dentists, they've got this more holistic, kind of approach to it, and it's a marathon, not a sprint. Whereas I suppose we're from the generation that try and sprint our way to the end and wonder why we burn out.
Sprint in the marathon.
Which kind of isn't great, is it?
No.
Do you have any New Year's resolutions, Rob?
Not really. Just
work a bit more.
Yeah,
there's a few hours left
Sundays
on a Friday.
just clock the idea of Sundays. I thought, we could, that might work.
Double time.
No. I mean, I think just kind of ultimately, I'm kind of I'm in this kind of transition, aren't I? And just trying to keep walking towards that transition where I can slow things down a little bit, really. I'm desperately trying to get better at golf, but still awful. Still really, really awful. But just I think we're so lucky to be part, Simply Endo, aren't we? And it's such a privilege, really. And just keep doing more of that, really.
What about you, Dave? Should ask you.
I've got anything. Every year, I get told I need to be slightly more organised. I'm like organised chaos. I'm one of those people who, if you go and study, there's stuff everywhere, but I know where everything is. Maybe a bit more organised with stuff. No, I don't think so. I think maybe delegate a bit more in the practice, because I'm better at that. But you find it hard delegating stuff and then knowing it gets done. Like I think when I first took over the practice, because we weren't that busy, to be fair, every email that came in, I would answer. It would be me who would answer every email.
And if anyone's ever spent any time with David at a conference or something like that, he's always checking the works emails in the break. Just have a look. There's 2 receptionists on. And checking the answering machines as well.
Because it annoys me if you think. For me, if patients email and they get answers straight away, they go, "Wow, thanks for getting back to me so quick." And then also the problem's kind of done then, isn't it? If they've broken the tooth, they're booked in or whatever. I do find it weird sometimes that patients email about a problem rather than just ringing when the practice is open. It takes longer, surely, to email than just ring. But
not our practice.
I think
we can never get through.
think I need to be a bit more, to delegate a bit more, maybe. In terms of like endo stuff, I'd just like to keep getting better, really. I think, I think it's a bit of it's a strange world, isn't it? Because a lot of stuff that we look at is all judged on Instagram and things like that. And I think a lot of it is probably nonsense. People are not going to post rubbish, are they? I've fractured a file and I'm 4 millimeters short. Let's put that on Instagram. You're not going to do that. They're only posting good stuff.
I watched an interesting YouTube video over Christmas. That's how sad I am. About Alan interviewing. What's the guy that Mike really likes? The Italian guy. Can I ever get him on? Ricucci. Yeah. And it's a part 1 and part 2 video. And it was really interesting. I think it's called something like "Where Did Endo Go Wrong?" It's from a few years back. But he made some good points, Mr. Castellucci. He was like, famous, like, he's like Rob to the next level, isn't he? He like does his work and then he goes and cuts all the teeth open and granulomas is scraped out, and then he stains them and looks at under a microscope. And the nature of the interview is that I think Mr. Nasser was just saying, why do you think endo's like not improving and stuff like that? And he was basically saying, he says, because it's like the university of Instagram and YouTube. Like people just end up copying each other's images because that's what they're comparing themselves against. Instead of like, nobody reads journals and deep science and stuff. And I think there's advantages to both. I mean, we haven't got time to be reading reams and reams of journals, but the underlying point is important, I think, is that sometimes we just do stuff because we've seen somebody else do it and go, oh, yeah, that must be pretty good. We're all guilty of that. But the science behind stuff, he was saying, he was sort of ruining the fact that people don't like sit down and digest the information properly before employing it in their practice. Instead, they'll just go, oh yeah, like thinner preps, ninja access, that kind of stuff. Don't get me started. Well, he was going bananas about it. Not that he's worth huge preps and stuff like that, but he was just going, people just don't seem to understand the science of endo. On that, the thing that, this is my take-home message with the skinny preps and stuff, and we can finish off now, but the teeth that you see where they've got huge amalgam restorations in them, absolutely massive, and someone's gone, prep to an 04. Yeah. But what for? I'm preserving dentine. You go, you're not. That tooth's not going to fail because you preserved dentine with your 04 prep. It's going to fail because there's bugger all left of it anyway. It drives me mad. That bless you, Lee. That would be an awesome podcast, wouldn't it, chat? Well, it would just be me ranting to be it would just be me having a right kick off about it. We on our alumni day we talk about minimally invasive endo and the kind of where it comes from, and I won't go into it all now, but it's a great
podcast day.
I'm itching on. I am itching to go. But no, it's fascinating where it all comes from and how there's very little evidence for a lot of it, as we know, isn't it? So, and going forward with practicals with Simply Endo is one of the things that we've tweaked a little bit for the new year, really, which is people doing various access cavities as we go forward, and from the sort of more traditional to doing the minimally sort of ninja access cavities and seeing the difficulties with doing that, which that's good. But well, thanks so much, chaps. Thanks for your time. Good to see you both. And
great chat to you. Great chat.
And Ben, the Wizard of Oz, in the background.
And Ben, thank you for being in the background organising this. This is our
thanks for having me.
What are your New Year's resolutions, Ben?
To replace, I call it doom scrolling. So to replace doom scrolling with reading. I've got a ton of books. I have a habit of buying books and never actually reading them, but the pile just stacks up. So,
but they make you look clever, though, don't they?
Exactly. Yeah. So just replace that and just learn as much as I can, really.
Good stuff.
Right, chaps, I'm going to wish you all a happy new year.
Yeah, happy new year to you both.
Best for a happy and healthy 2025. We should have flying cars in 2025.
Yeah, I know, Jetsons.
Jetsons.
Supposed to have a robot to clean the house.